Without further ado, I'm going to turn it over to John and our panel.
Great. Thank you, Jeff. Thanks. Well, having a bit of a delay on the way down here from New York this morning and landing just about 30 minutes ago, I feel fortunate just to be here. And I promise to try to make this a valuable session. Really fortunate to be here with three thought leaders from leading healthcare carriers, insurance companies, and medical systems. And the topic is so important today in terms of trying to strive for value-based healthcare and align incentives across payers, providers, pharma companies, and of course patients. So maybe to start off, let's just begin. If the panelists could just introduce themselves in terms of their role in their systems and define how you look at value-based healthcare in your particular system.
Sure.
Katie.
Yeah, thank you. So working with Humana, I stay in the corporate arena, but had previously been in the market arena. For you out there in the audience, as a provider or a facility, what I would be pivotal in helping you with is setting up the value-based contract along with the applicable market. And then we would also continue that relationship to make sure that we're succeeding together and getting the best care for our patients. As I see value care, I've actually seen boots on the ground. I know a couple of faces in the audience that are doing very well. And I think it's a collaboration. It's a relationship that we develop together, and we provide the utmost quality of our patients together and making sure that you get what you need to deliver that care.
Thanks, Katie. Alefiyah.
Hi, my name is Alefiyah Mesiwala. I am the Senior Medical Director for Value-Based Care and Innovation at UPMC Health Plan. In that role in particular, I kind of oversee both our a whole portfolio of value-based care initiatives clinically. I really engage with our physician leaders, both at UPMC, University of Pittsburgh Medical Center, and then kind of across the state. And then, as Katie mentioned, a big part of what we do is building that partnership and kind of developing the teams so that we can really enable successful implementation, operation, think about population health, data, et cetera. I think all of these things will come up as we have our conversation. In terms of defining value, I think it's really important to understand what type of plan we are. We're somewhat different than Humana and United Healthcare that we have my colleagues here on the panel with me. UPMC is the second largest integrated delivery and finance system. So we are a distant cousin, I like to say, to KEYNOTE. And so to give you a sense of kind of our reach and who we are a regional health plan. So in the state of Pennsylvania, we cover about 3.9 million lives. Our largest business is in the Medicare Advantage space. And then we also are one of the largest Medicaid providers in the state. I think we might be the largest, actually. And then definitely the largest behavioral health payer in the state. And our growth and experience as a plan has really arisen because of success in managing complex populations. The other thing I would add is that unlike a KEYNOTE, we're an open network. So 35% of the physicians that are part of our health plan are owned by UPMC, so they are employed by the University of Pittsburgh Medical Center. But 60%, 65% of our network is really independent physicians. And so what that means is we have the same challenges, I think, that my colleagues here will be speaking to, because we really see all of the United States and the state of Pennsylvania. I think the famous line goes that between Philadelphia and Pittsburgh, you really see kind of the entire USA. And so we really do kind of have an interesting world in which we live in that we both have own physicians and opportunity because of the shared architecture that we as a payer and provider kind of bring to UPMC, and then kind of the challenges of being a payer for a very large network. I'll give one more line around how we define value. I don't think that our definition of value at the broadest sense is different than the speakers earlier today, and then folks kind of, and my colleagues, whether you want to talk about triple aim, quadruple aim, I think we generally, I would say, agree at a very high level what value means. I would say that for what I personally believe, and I think what our health system is really kind of embracing, is that value-based care, or value, is really a euphemism for the disruption and care transformation that has to happen to really kind of change the entire healthcare system. And so I think at UPMC, because we're both a payer and provider, we have the opportunity to really look at the business model from both the provider end and the payer end, and really try to understand how you disrupt that. And we can speak about this a little bit as we progress in the conversation, but the three areas that we've really focused on, or that we're kind of really driving as we think about value-based care, realizing that this is what we need to be successful, is one, really creating that learning health system. So again, it goes to how do we leverage the assets that a payer brings and the assets that the provider has, and really kind of disrupt the system and create that learning health system. The second bit is data. And I think using that data to really really drive care in the right direction. We're lucky that as a large healthcare system, we've made the right investments, and so now it's really kind of leveraging that. And then finally, care transformation, and we can speak a little bit more about what that means to us as we progress. So those are the three, I think, primary drivers as we think about value at UPMC.
Thanks, Alefiyah. We'll definitely follow up on all three. Anthony.
Yeah, so at United, we're focused on value-based care, obviously, and my role is to drive greater success for our providers. Yes, we have over $75 billion in value-based spend this year, but the metric that I challenge my team and myself on is how can we drive more shared savings? Value creation is what we focus in on. So of the $75 billion, how much are the providers getting? And that's really important to me and my team, because as we're focusing and helping the providers achieve that triple aim, we can't just sign a contract and say, okay, that's it, and good luck. We're focused on having tools and creating the infrastructure to help them achieve that value creation. So every day my team has over 100 people out in the field working with the providers, and then we also have an area under me is the consumer engagement team. And so this is really where they're creating tools on behalf of the providers to help them engage the consumer in different ways. And that's critically important. For us, defining value-based care is how can we help the providers generate more shared savings and give them tools to engage the consumers on behalf of all payers in a more sticky way.
Anthony, thanks for that comment. I think that consumer engagement is really key, it seems, to driving more value in the system. And just, as a representative of PFIZER, just for the past 6 months, kind of going out there and meeting with a lot of national and regional payers and some IDNs, it's been clear to me that everybody is striving to get a better integrated view of patients and looking at holistic factors, including social determinants of health. And Katie, that was something you and I talked a little bit about. Maybe you could comment on how your organization is looking at social determinants and the value equation.
Sure. So we all are probably familiar with the new, it's not really that new, but social determinants with our patient population. Here at Humana, we have a dedicated team. They're called the Bold Gold team, but they address the top three along with other determinants depending on the area. Those determinants are lack of transportation or difficulty getting transportation. Food insecurity is the second one. And then the last one is loneliness. And so what we found at Humana is that not only are providers trying to get optimal care to their patients, but you're also impeded with these social determinants. And so here at Humana, not only have we identified them relative to the areas that we have Medicare, so it's essentially nationwide, but we also work with your individual practices and how is it that we can succeed over these determinants that are becoming hindrance. We would rather propose that we have less unhealthy days of our patients and we want to strive to get healthy days. So the question you're probably asking yourself is how do we do that? Well, an example is in San Antonio, we not only work directly with providers and prop up, is it a transportation issue? Is it a loneliness issue? But we're also networking and working with arrangements and relationships in the community. What organizations in the community provide for the food insecurity? Where are transportation resources? And then we help facilitate that pairing and bring it all together.
Thanks for that, Katie. Alefiyah, I know that UPMC is very active on this social determinants front and made some news about helping patients get mortgages in some cases. for housing. Do you want to make a comment as well on social determinants of health for UPMC?
Sure. So I think, John, as you said, we have been very active and really trying to understand kind of where's the evidence so that we can really invest in social determinants of health. Similar to Katie, I think our focus areas have been food insecurity, transportation, social isolation, and then housing has also been a really big area that we have actually have had a long track record, actually about a 10-year history of doing innovation in that space, and have now really invested some dollars and committed to housing. I think, I mentioned earlier that our goal ultimately is to be a learning health system, and a learning health system is also, from our perspective as we've defined it, also one that is really engaged with the community. And so we are trying to figure out what that relationship with the community looks like, and maybe to even reflect on a comment that the earlier panel made today. I think it's payers, given where healthcare is moving, and really just to be able to optimally manage the population, really do need to think about investing in social determinants of health. But I think it is going to be an interesting question for payers, and UPMC included. At what point are we willing to invest because it's for the public good and not necessarily for our ROI? I think that's a question that's going to be, that has to, I think, come up as part of the policy dialogue in healthcare. So yeah, and I think maybe the one additional comment I'll note is that we have, for 8 years, we have participated with HUD on a housing pilot, housing program in which we provided housing and paid for housing for the chronic homeless population in Pittsburgh. We've actually expanded and scaled that, and we've been able to show some phenomenal savings, an average of $7,000 PMPM per individual that was enrolled in the program. A lot of those costs being able to reduce unplanned care in that population. So I think we've...
So not only driving better patient outcomes, better population health, also saving money?
Yes.
Wow.
Eloquently
Triple
said.
aim action.
Yeah.
So Anthony, you mentioned consumer engagement, and we hear a lot about consumer-driven healthcare. We've been hearing a lot about that for the last 10, 15 years or so. But it does feel like times are different now, and maybe it's the advent of advanced analytics, artificial intelligence in healthcare, and just better access to real-time data. But you think of other B2C businesses and technology-driven businesses like Apple and Google and Amazon, where everybody gets the information they need personalized whenever they want it. How do you grapple with that at UHC in terms of becoming more consumer-oriented?
Yeah, so let me ask, how many people here use Siri or Alexa or Google, asking them to do, what's the weather? How many people use one of those voice? Yeah, a lot of people. So the data shows by the end of next year, more people will use the smart speakers or voice search than in any other channel. So as that grows, as consumers now start using voices first, that's really where we want to go. So in terms of social determinants, what we're focusing in on is how do we make it easier for that 75-year-old Spanish-speaking only Medicaid member to access healthcare. She's not going to know where to call. But here, if we create it on the voice skill that the provider, it's the all-payer solution, the provider pushes out on behalf of our Medicaid members, then now that person in Spanish can ask, Alexa, open, USC in Spanish. And then now she can say, find me a doctor. So using AI-based logic, we can now pull up the claims and match her to the right doctor at USC, and then also serve up appointment, available times, and then not only that, go full circle and say, do you need transportation? And through our APIs to Lyft or anything else, book the transportation, and then now follow up. So those are the type of things that we think about in terms of social determinants. How do we now close the loop? How do we create skills that providers are actually going to push out to help them engage their consumers or their members? That's really where our head's at.
And to do that type of work, it seems very data hungry. It seems like you need access to not just social determinants data, but also medical claims data, EMR data, lab data. Maybe you could comment on. I'll give the other panelists a chance to comment on data
so
too.
if, like, for instance, the provider skill that we have out today, you guys can Google it and try it for USC, and we're launching it with a number of other ACOs. That initial skill, that's just phase one. Next phase that we're doing now, if it's a Anthem member, hey, we just give the random sort. because it's not our member. It's a United member, then now in real time we can pull up the claims and then now match the doctor. But then we use also logic with social determinants like Match.com, right? Do you know that more people use these dating services and get married than any other channel? And that's really where AI is today. And if we can now apply some of that and also tap into the DNA, genotypical data that we might be able to have access to, we can really take healthcare to the next level and at the point of request. That's where we're going. So within milliseconds, we can now pull up data, match you with the right person, and then serve that up in your native language. And I think that's really where we need to go.
Thank you, Anthony. Alefiyah, you want to make a comment too on data and analytics?
Sure. So, I think everything that Anthony said, I think, and approaches to consumer engagement using data, I think really resonates with the way we're also looking at the universe of how do we better engage our members. Maybe I think, and we've also really tried to create partnerships with our local health agencies. We also own a very large business around workers' compensation, disability, et cetera. So looking at how do you integrate some of these other types of data to really get the full picture of the individual. So I completely, I think what you're saying really resonates. But I think when we start talking about data and AI, I think the big issue that often, kind of comes up is the fact that we're still not really interoperable as a healthcare system. And sometimes you can take all of this great data and yet it still sits in bubbles that we can't really connect well to. We've really tried to lead and push efforts around health information exchanges. But again, it's just so unfortunately in Pennsylvania that we've had some more uptake in the last couple of years. So, and I know that now the conversation is really focused on the patient and enabling the patient to really help move that data and kind of give access to data, but that's going to require significant kind of patient member education and engagement. So, we're making all the right investments. We've got a $1 billion partnership with Microsoft in which we're trying to really understand and use AI and bring all these different data sources. But ultimately, what we really need to figure out is how do we get to a point where that data doesn't belong and I think data is one of these things that should really be a public good. And really, instead of owning and hoarding the data, I think stakeholders really need to release that data. And really, you should be winning because you're able to use that data well, not necessarily because you just are hoarding that data and not sharing it in the market.
Which also feeds the learning system you mentioned before. So Katie, maybe you could talk about Humana and data initiatives.
So I will agree, there is a ton of data out there. I, like most of this room, had practiced probably about 8 years ago, and I remember the beginning phases of data coming in, and I was like, well, I don't care about these gaps, and I'd circle file it. And now I'm on this side of the fence, and I realized that it is almost too much information. And so when sitting at Humana, the first thing I had to understand is how do we take all this information and make it useful so that you, the providers, facilities, can actually have something tangible and actionable to go out and do something with. And so to lay the landscape, there are 16 Medicare markets within Humana throughout the company. We're pretty much from Seattle, Washington, all the way down to Miami, Florida, and then up into Maine. Depending on those markets, you actually now get access into a data portal, and you can set up your quality metrics based on your value-based agreement with the Humana, and you can go into that computer program and you can track your quality metrics on how you're doing. Now, I will say that it's not flawless, and we certainly have facilities and providers with their own data, but you're also with a dedicated team in the market, and so you and that team sit down and you analyze and validate your data and our data, and we make sure that we're speaking the same data when we talk about setting up the value prop and getting our agreement.
So if we could build on that, Katie, I know that you have a lot of experience in developing value-based agreements with providers, which of course are data-driven. So maybe you could comment a little bit about the quality metrics you look for or the process metrics. Maybe you're looking at total cost of care.
Yeah, so what we do with these 16 markets is every market is just a little bit different. So I can't say today that it's one size fits all. We finesse it to where you are, what are your social determinants, where the patient population, where are the underserved, what gaps do you need closed. And the other thing that we're starting to collaborate with is, as you can imagine, all the other payers have gap closures as well. And so we're trying to overlay this synergy so that when you close a gap, you don't have to think about, oh, is this payer or is it this payer? I mean, that's going to drive you nuts, and you have way too many things to get done that day. So it's about synergy of aligning the targets. The targets are unique to probably your market, but then there's also the usuals that we have, the gap closures that run with stars and HEDIS, diabetes, cholesterol, just to name some high-level few. You have my information. If you want contact, you can find me. I'll help you.
Yeah, Alefiyah, sure, please.
So, I would actually, I really commend NCQA and their kind of recent announcement of changes to their star ratings, or kind of introducing star ratings and aligning that to Medicare. And actually in the state of Pennsylvania, even Medicaid is now kind of aligning and creating a star system. I think one of our biggest challenges with our contracting space, and similar to what Kate mentioned, is just really being able to align across all the different payers and the different programs. And since we offer value-based and our contracting is across all lines of business, it's sometimes a little bit of schizophrenia when you say, well, how do we incentivize a payer, a provider who might have a pretty good portion of commercial and Medicare and 20% is Medicaid, with all the different metrics. And so I think what NCQA is doing to really line up, it's kind of creating that star system and then lining it up across Medicare and Medicaid is really resonating as the market is changing. But I think otherwise similar challenges to what Kathryn said. It's really difficult to try to kind of with every provider, it is kind of a song and dance in terms of which metrics to really choose and kind of incentivize.
You said something before about practice transformation, and maybe you could just explain that a bit further, because it feels like that fits here in terms of looking at the providers.
Sure. So I think one of the, I think that successful value-based care contracting requires really good, successful implementation and operations. And one of the things that I kind of, as I moved into this role 2 years ago, kind of evaluated our teams and looked at kind of how we engage with our physicians across the state. And, and realized that we really needed to kind of completely disrupt how we are going out into the field and engaging with our physicians. So a big part of that is practice transformation. But first and foremost, it's really building that trust. I often go into offices and I'm talking with physician leaders, and they're no different really than my father, who's a physician, and my mother-in-law, who's an OBGYN. And if I can't convince, so usually, it's folks like me who are relatively younger physicians, kind of in this, I got into value-based care right when the Affordable Care Act got passed. I was at CMS and CMMI and then in the White House. So I come with a different world vision of where things can go, but being able to really sit down and connect with physicians, middle-aged, especially in primary care, who've been doing things a certain way for the last 20, 30, 40 years, and to come in, and I sometimes would listen to our teams and just listen to the, everybody is well-intentioned, whether you're on the payer side, the provider side, the reimbursement team, the contracting team. I think that's the one win of the Affordable Care Act, was that it really has focused on value, has really focused on patient outcomes, and so I think everybody, for more or less, is marching towards that tune, but our world is so different in terms of how we speak and communicate. So one is completely trying to get rid of the jargon when we're speaking with physicians, but then really realizing that when you're working with physicians, you've got to really understand the reality of their day-to-day lives. So one has been really building a completely new type of team. It's a team that can go in there, and we've created a data resource for every physician partner that they can call, kind of available to them 24/7 to run to kind of review data, deep dive on data, cut reports in the way that physician partner would like. So we have a strategist, a value-based care strategist role. And then I've also hired folks who are really focused on process improvement. So, again, I think the assumption with value-based care is that physicians, if you just put them in the right type of contract with the right types of incentives, they know exactly what to do. And one of the things I've been challenging folks is that, no, there's a whole set of change management skill sets that somebody's got to own. Providers don't have those change management skills. Frankly, a large, UPMC, a $20 billion healthcare system doesn't have those change management skill sets. So especially for our smaller independent physicians that we're working with, we've got to bring some real core methodology to the ground in terms of how do you actually standardize and scale best practices, and then most importantly, as others have said, we have so much data, but how do you actually connect clinical workflows with the data at the point of care with their specific patient populations and actually have it make sense? And you have to tailor it to their local offices. And so we've got teams of folks who really go inside of the physician's office and say, let me do an assessment. I'm going to provide a consulting service to you and kind of assess their workflows and say, well, here are some programs, here are things that you can be doing here, and kind of really help the physicians. And it's not just physicians. Again, it's really a team-based care approach. It's really kind of having all the individuals in the office understand what value-based care is and what the whole office should be driving towards and what they can do.
Thank you. And Anthony, I know United's such a major player on the provider space too. Optum Care comes to mind, and how you guys continue to vertically integrate. Maybe you want to comment on the provider space as well.
Yeah, so the challenge with value-based care and providers being successful is that there's a lot of them that don't have the infrastructure such as a UPMC. So a third of our members that are providers that are seeing our Medicare Advantage members, they're seeing less than 30 of our patients. And so that's the problem. We have so many smaller providers that don't have the infrastructure. So what are we doing about it? Well, we're just going to do it for them. And so what we have been doing is hiring up pharmacists as well as care coordinators. So we've designated them to particular practices. So they go out there, a pharmacist sits in front of them and now discusses the panel of UHC members that they have, and then now recommends evidence-based care formulary as well as care coordination referring to specific specialists. So we're actually going out there just to do it for them, and then now let them share in those savings.
That's great. So we're about halfway through, and just want to give a heads up to the audience. They can ask questions, but I'm going to a whole list here, so I'll keep going if you guys don't have any. But I do have one question I want to ask the panel to think about, and I'll each give you a chance to chime in. When we were preparing for the panel, we talked about some examples in your institutions about you're trying to implement these value-based programs and you're running into some operational challenges. And if you could maybe speak to one example where you've overcome those operational challenges and how you've done so. Because I think strategically, a lot of people out there, they're all in because these are great ideas. But then you get out there and you try to implement them, and you've touched on a couple of the challenges, but maybe you could kind of speak to one initiative and what you're doing to overcome some of those operational challenges. Katie, we'll start with you.
So alluded to this a little bit before. When the provider group want to sign up for value-based care, you outreached into Humana, and we have a team called Provider Simplicity that are distributed amongst the markets, and it's a plethora of clinical staff as well as strategists as well as just boots on the ground to help facilitate your needs. One example that comes to mind is in Virginia, there is a group that was interested in value-based care. It was a smaller group, about 10 physicians, but they had a strong hold on their community in terms of the membership enrolled with Humana. And so they reach out to an article that Humana had published, and then that funneled its way to myself, and then I reached out to the market and I said, guess what, Jim? let's go out. So we go out, we visit, we set things up, we figure out, what they see it, how did they see it look, how did we see it look, and pair up, showing the resources that we have and the resources that they have. To date, in the course of my short tenure, so about 2 years' time, they have gone from a full risk model. They're doing very well. It is about monthly, sometimes bi-monthly, face-to-face meetings. It's about their continuum of data. Like I said, they have a computer platform that they get live-time data that they can check every day if you want. And then any phone call or any resources that they may need. So if it's case management, we've got resources. We help script with case managers directly from the community versus the 800 corporate line, and you become in the phone tree. And then again, the social determinants in this area, we did a lot of resources with the community support so that we could get the member set up with the needs that they needed, and it was sustainable. It wasn't like, oh, here's a one-night wonder, and then 6 months from now that member has no transportation, no food, because the benefit is gone. And so that is not our intent. Our intent is that we're going to teach that member how to use the community and its resources so it's sustainable.
Thanks for that, Katie. It seems like in your case, high-touch communications and data exchange were key to overcoming the obstacles.
Yeah.
Alefiyah.
Sure. So I guess one of the areas that, we have so many operational challenges, it's like where do you begin? But I think one area that we have really wrestled with is doing provider profiling well. Our goal ultimately is to move as many, of our large PHOs into a risk-based, capitation type arrangement. And we know that one of the things to really help these organizations is being able to do provider profiling well. Now, part of it is that it's our own kind of handicap. So we are a very large academic medical center, UPMC is. And so one of the challenges is that when you kind of use some of the traditional, if you just, let's say, look at cost or efficiency efficiency assumes you are. So if you were to look at both quality and cost, as metrics, UPMC probably comes up as the most expensive every single time you cut that data. And so one of our challenges has been internally, we don't really, politically it's difficult, as a UPMC to put out a profiling metric in which we are always the most expensive in every single category. As you can think, again, I wear that IDFS hat where we're both the provider and the payer. But then as a payer, you really want to drive, efficiency in the market. And so how do you do that? Well, and one of the things that we've learned as we've kind of pulled apart some of the algorithms that are out there, whether you're using a Truven or you're using the CAVE tool or there's Roadmap, any of these kind of big profiling, vendors and tools that are out there. I think we've looked at, even what Optum has to offer, is that, ultimately, risk adjustment and really doing good risk adjustment that isn't just HCCs or the Charleston Comorbidity Index or something like that, like really a nuanced algorithm that takes into account a lot of different factors, is really still not out there, or at least and so we've had a real challenge putting together provider profiling. And so ultimately, the way we are finally making some strides, we are committed, even if UPMC looks bad, to get that information out, but we want to have a methodology that's defensible so that when you take it to a physician who is a quaternary specialist, at an academic medical center who specializes on not even one ventricle, but one, electrophysiological pathway, in a heart ventricle. You want to make sure that their information is accurate. And so the way we've gotten around that is really kind of is creating work groups with physicians in our market. and making sure that like there's a ton of provider buy-in before we put out any sort of profiling type of tool out there. And our goal is to go specialty by specialty, so that ultimately it may take long, a couple of years to ultimately get there, but that ultimately when we do put something out there, it's been vetted by the primary care physicians, vetted by the specialists in the market, and it kind of can serve as a source of truth. Or not source of truth, a source of collected, kind of collective agreement in terms of the data that's being out there. But we've really wrestled with that.
Yeah, I'm glad you mentioned the joint working group, the idea of a multidisciplinary team. I'm finding that just as a member of PFIZER going out and talking with big payers, it's clear that you need to have providers at the table as part of the conversation, because you can end up creating a value-based agreement with metrics that don't work in the clinical workflow, or they just won't be operational because of capacity constraints. So I think that's a really key point. Thanks for making that. So Anthony, maybe you want to talk about some of the challenges you've overcome at United.
Yeah, so there are various challenges, and every provider group seems so unique. So how my team and I approach is, first we have a maturity curve. So when you want to start with us, kind of how the progression is going, and then we have metrics that drive that maturity score, and we have timelines and goals. And then if you fall off that, just like a kid that's a maturity like 10% of their height, this is there potentially you need to do more interventions. So we have that, and then I also have personality profiles, just like any of us, right? We all like to have taken the Myers-Briggs. We have personality profiles for our ACOs that we kind of identify them as such and work within that profile. So a profile could be like a committed carer. So they care about it, but they're not so sophisticated. And maybe an FQHC, not so committed to data because they don't have those capabilities, or they have a prime potential where they're really gearing up, investing into pop health programs, but they need different support. So again, maturity curve, personality profiles together, we're able to now uniquely identify and now apply specific interventions.
Thank you, Anthony. Looks like we have our first question from the audience.
Hello, my name is Ryan Russ, and
The mic's not on.
Maybe if you could, just state who you are and where you're from.
okay, hello, my name is Ryan Rust, and the question that I have, I know that so far we've spoken a lot about value-based care, as it looks like between payers and healthcare providers. I'm curious, if you look at the other side of it with pharmaceutical manufacturers, do you think that those value-based opportunities are complementary to what you're trying to do with the payer-provider relationship, or do you feel a big disconnect if you look at value-based agreement opportunities with payers and pharmaceutical manufacturers?
Thanks for your question. So I'll open that one up to the panel, because I think it's a great question, right? Because I think a lot of pharma companies are trying to figure out how to design these value-based agreements with payers. And as I mentioned before, it's important to take into account the provider agreements that you all have, because maybe there's a way to reverse engineer the pharma agreements so they fit with your provider agreements. But what do you all think? Maybe Anthony, you could start.
Yeah, so we're completely open to it. I mean, we have value-based contracts with device manufacturer like Medtronic, for instance, for diabetes. I mean, I'm completely open to it, because one of the things that we're solving for all of us in this room is medication adherence and compliance, right? Mm-hmm. And so 50% of people actually take their medication. That's a problem. So if we can create better tools, and so it's not just dispensing the medication, but actually getting them to take it, then we're all for it. And so those are areas that we welcome at United. I mean, we're looking at, right now we've done a couple patents, and we're about to launch a med compliance tool with now where the consumer is using a device where they click on it for a few days, click on what medication they're taking after we pulled the medication from the EMR and PBM. They click on it. So then on the app that we have, it also locks in people's geolocation as well as where they went previously, obviously privacy concerns. But then I know now Monday, Wednesday, Friday, John usually takes his medication after he drops off his kids at 8:10. And then now we start pinging him if we see that he has taken his medication, and then we use the smart speaker to now send the notification. So all these things, we're open to collaborating with manufacturers to really, again, it's about consumer engagement tools to drive behavior change, and that's what I'm fixated on.
Thank you. Alefiyah.
Yeah, I'd like to add. So at UPMC Health Plan, we've actually created a center specifically focused on value-based contracting with pharmacy manufacturers. It's called the Center for Value-Based Care Initiatives. Actually, I should put a plug in for my colleague, Dr. Bernie Good, who's also in the audience, and will be doing he leads that center and has actually led the efforts in value-based contracting with our pharmacy manufacturers, and we'll be on a panel later this afternoon, so you should all go to that. But not everybody, because I'm also facilitating a panel, so somebody should show up to. I think the one thing, so we recognize that there's an enormous opportunity to work with pharmacy manufacturers. I think, and for the most part, we've seen really good interest to actually come sit down at the table and have that conversation. I think actually one of the challenges we find is that a lot of the contracts that come to us are often cookie cutter contracts, generally chasing either intermediary outcomes. So like, for example, A1C, kind of A1C gaps, or often medical compliance type outcomes that the pharmacy manufacturers often give to us. And frankly, from our perspective, being a payer and also having a specialty pharmacy, having a PBM that we work with, like those outcome metrics are not that valuable to us. I mean, that's kind of what we do as a payer. And so, I think our challenge has been how do we have a conversation around different types of outcome metrics with our pharmacy manufacturers. And we're fortunate because we have a dedicated team led by Dr. Good, of physicians, health service researchers, data scientists. We've got a whole team of folks who really kind of work with this data, understand the data, and are kind of leading the, kind of helping facilitate a different type of conversation with our manufacturers. A lot of it's included just working, surveys, bringing in, we're also, given the payer-provider hat we wear, we're able to bring physicians and patients and the pharmacy manufacturers in the room together and say, well, what are the outcomes that would matter in a particular outcome-based type contract? And so that's been kind of the approach that we've been taking. We've had some success. For example, we have a contract with Jardiance. It's a SGLT2 inhibitor for diabetes. And that contract, we were able to kind of steer the conversation away from kind of process outcomes to a total cost of care type contract. Another contract that we're working on, it is focused on really kind of a different set of outcome metrics altogether, where we're looking at work-related, it's a MS drug, and we're looking at kind of work-related disability outcomes. So we're trying to bring the data, bring the team of folks, and really work with the manufacturers to help them think differently too, but it's really tough. And Bernie lives it day in and day out and can speak to all of it if you go to his panel.
Yeah, look forward to his panel. And
Kate,
you could disregard the music in the
Oh,
background.
I
It's
was
like
just
the
going to
Academy
say, the
Awards.
music's playing,
They're
we're
not-
done, we're out.
We got
See
some
ya.
time. Yeah.
Unless you want to get the question back.
No, we'll give you a chance to answer as well.
Yeah, so in 20 seconds, because I want to be sensitive to the time. I think the issue, it's not really an issue, but what I've seen within Humana is it's about the access to the medication for our patients. I mean, we all see the front line, we all know the drivers, and the last thing we want is to have a patient unnecessarily end up in the hospital. So it's about coordinating our teams with the providers and the hospitals of making sure that the medication is delivered for that patient so that they can remain as compliant.
I think we can all agree with that. I think there's a question in the back.
Hi, my name is Mason Reeves with Cemetery Health.
You have to yell, your microphone's not on.
Or come to the front.
Hi, my name is Mace DeVries. Try that again. Long run. My name is Mace DeVries with Cemetery Health, and the question I have for the panel is, given how health plans themselves are still siloed, behavioral, medical, pharmaceutical, et cetera, how can a provider demonstrate their overall value to a payer when the payers themselves still remain kind of fragmented that way? Especially for a provider that can demonstrate savings in the medical world, but they contract on the pharmaceutical or on the behavioral side?
That's a great one. Pharma companies can learn. I'm listening. So what do you guys think? Anthony, you want to start?
Yeah, no, we suck.
Didn't want to say that.
Can I tweet that?
Hashtag.
I mean, let's be honest. So I'm not going to try to sugarcoat this. I mean, look, there's absolutely, when I think about some things that we do, focusing on the medical expense on the pharmacy or the retail, I mean, it doesn't make sense to me. And when I think about behavioral health, when that might drive up the cost for behavioral health care, but drive down medical, I mean, that's exactly where we need to go. And then when I think about the data that we're giving to our ACOs, and because we're so damn concerned about, PHI, and we blind all this data, there's huge opportunity. So I'm not going to even try to say, we're making inroads. I give you that, but day in, day out, as I engage our 500 plus ACOs, I mean, those are challenges that we need to work through. Is how do we get that data? How do we integrate that data in a more timely manner, so that now it's actionable at the provider level? And how do we look beyond just our own cost center? So if the value-based contract is just fixated on the medical expense, but you know what, you're driving up maybe a cost for pharmacy, I mean, that's a good thing, right? We should be paying for that, or skilled nursing facility versus acute care. And there might be different buckets. So we're trying to realign all those, working with the providers, especially our employers, so that they understand it, right? Then on the employer level, they go out there and, any of our large clients, maybe they'll contract with, a different, not Optum Behavioral, but a different vendor, and then a different vendor for, not Optum PBM, but a different PM. Then it just gets difficult. So, you know what? Come to United, we'll sell you a whole solution, and that's the beginning of it.
We're not as big as a Humana and United, smaller, so I think, but yet still fragmented. I think we recognize that. Again, we have lots of providers who have contracts with us across all lines of business. We've tried to take the value-based contracting and put it all under one shop, so that when I'm putting together a contract with a provider, I am negotiating for all lines of business kind of in that one conversation, and then we try really, it's the same shop that does the data, it's the same shop that runs quality, so we try in our kind of communication and analyses to try to highlight the opportunities across all lines of business and try to really be able to show a more population angle. But in many ways, we still suck. I think we realize this internally, so we're actually developing, nothing's out the door yet, but we actually have a work group that's looking at how can you build a Medicaid, so we're the largest behavioral health payer, and we're also one of the largest Medicaid payers. So we know that savings on one end impacts the other line of business, and and the behavioral health savings often impacts the Medicaid line of business. So we actually have a work group there looking at thinking how can we develop a value-based care model that really is seamless across the two payers and two different lines of business. So we know that there's that opportunity. The other area that we are trying to integrate, and this is value-based care it's also a disruption and kind of transformation process for payers, is we're trying to bring together all of our care management across all these different lines of business and say, the care management model is one provider and a population and kind of managing that entire population, rather than the Medicaid care managers and team doing something, and the Medicaid team and the behavioral health team trying to make it more seamless and share a common platform and common data. So at least that's the beginning of us trying to get to a place where we can start thinking about things more from a population angle rather than only line of business.
Great. Thank you. Katie?
So your question is well taken. I would say in Humana, it probably became much more real when we started our own proprietary provider network. We set up our own brick and mortar, and it was at that point that eyes became wide open with just exactly how frustrating and how siloed everything. So I empathize with you and the audience that there's a lot to overcome. It amazes me though how I can go on Zappos, which is a shoe app, and look at a pair of shoes, but as I go back to my USAID Today app, I see that the advertisements are the shoes that I looked at on the Zappos app. So if mainstream marketing, mania, whatever, can do that in like half a second, you would think that we would be able to deconstruct so that we can, share the data, and just because you're helping out one area shouldn't make it punitive to the other areas. So I don't have a magic bullet answer for that. I think it's a very well-deserved question, and we're dealing with it day in and day out.
Thank you.
So, thank you.
Thank you.
Time for another question or two if anybody else has one, but in the meantime, I'll ask a general question to the panel, give you each a chance to respond. So with all the regulatory and legal requirements in this industry, and also the asymmetry in the market we always talk about in terms of information exchange, and some of the things that you were just referring to, Katie, about the lack of pace that we have compared to retail. If you could change one thing in the healthcare system to improve value-based healthcare tomorrow, what would it be? Anthony, we could start with you.
So I would, United, we've got to focus or make it a frictionless experience. And that frictionless experience, like, when Katie's talked about going to Zappos, I mean, how easy it to identify, get reviews, and then, check out seamlessly, even with one click. Healthcare, you can't do that. I mean, how difficult is it for all of you to really get an appointment with your doctor? And so that frictionless experience is what we want to do so that consumers don't have to think. I mean, when we say, I'm going to empower the consumer and they're going to choose, and they've got an HSA now, they're going to shop wisely, that's just crap, because it's just so difficult. I think about my parents. They're not going to do that. And they don't really care, and we just make it confusing. So how do we simplify it? And that includes prior auth all the way down to on the consumer-facing side. So that's what we're fixing. Make it a frictionless experience where healthcare is actually catching up to other industries, and that's what I want to do.
Great. Alefiyah?
I think, and maybe this is more on the care delivery side. There is so much opportunity and potential with telemonitoring and telehealth. But even our most sophisticated partners who are managing, who are in risk-based, managing, moving to capitation, they still don't want to do telehealth. And so it's, and I think it's interesting because I think the earlier panel today mentioned, we definitely can't bring telehealth shouldn't be, introduced in a fee-for-service type architecture. But the reality is that telehealth isn't just like another visit, right? It requires a completely different type of infrastructure for partners. And so making the assumption that you can move to risk and that will just give it the business case to invest in telehealth for providers, we have not seen that prove in our markets. Because what most of our providers have told us is that telehealth requires kind of a new staffing model, new technology, new space, schedules. I mean, it's like setting up an office in itself. And so, folks aren't doing it on the ground, even though we're ready to pay for it, we're ready to offload some of those costs when it comes to the technology, work with our, independents to white label stuff. And so I think really being able to scale telehealth from an access perspective would be great.
Thank you. Katie?
Yeah, so I think in the ideal world, those who are doctors, I mean, we all went to medical school to give patient care. And it's unfortunate that we've had to also become business people and be more concerned about the business than the actual care. And so in the ideal world moving forward, we could actually get back to the roots and we could deliver the patient care, whether it's in the home, whether it's in the office, but we don't have to worry about all the things that preoccupy our day to day.
Great. So frictionless telehealth focused on the patient. If I could sum up the three comments, that's awesome. And we have, looks like the last question of the session. Back.
Hi, thank you. Tyson Park with a manufacturer. You guys have all discussed some of the operational challenges that exist. I'm in actual operations myself. And Katie, you brought up the idea of Zappos and kind of the scale that can exist with the tech companies, and how you can try to achieve that with healthcare delivery and value-based contract. I think one of the biggest challenges, how do you scale that, nationally? One thing that I feel like we haven't heard much about is the role that government could play, or really kind of going back from that, maybe what are some systematic ways that your organizations are communicating with the state and federal governments to try to, get at providing solutions that can be scaled?
You want to go first, Kate?
Yeah, so there are many states that I want to say probably in the last 5 years talked about, HIE, Health Information Exchange, mainly on the Medicaid platform. I think the good intent was, it made sense. What was disappointing is the layers that it took to operationalize that, and it didn't really come to fruition like I had hoped for. But that being said, I think it did open some opportunity for what needs to be done to get to that point. At Humana, we have a data and analytics division, and the skill set is getting into that area. And so it's going to be very interesting in the next, I would say 18 months of where we're going to go.
Alefiyah?
Sure. So how, as a payer, are we working with state and federal government? First, so I think UPMC, being the largest of the nonprofit health plans, has had actually a special seat often at the table with with the state of Pennsylvania, and then also with CMS, and I think federal government more broadly. A lot of our leaders, actually, including me, we are former government folks who've come into the health plan to kind of drive innovation and really think about different work and kind of help kind of continue to grow the health plan and UPMC more broadly. I think because we manage a lot of complex populations and our primary business growth has been in the government programs, we have a very open dialogue with our state, especially in Medicaid. UPMC back in 2007 created the patient-centered medical, it was a leader in creating the patient-centered medical home model more broadly, and then the state pretty much took what we had developed and kind of memorialized it in their kind of the DHS regulations and kind of the different programs that have come abroad, just to give you a specific example. I would say, to the credit of the Obama administration and under Seema Verma and the Trump administration, there has been actually a pretty regular and open dialogue with CEOs of health plans and provider systems. I mean, my CEO is going at least a few times a year to meet with CMS on various issues. We get asked to come into the room to talk about, we had a pretty heavy hand in trying to include the hospice benefit and flexible benefits for Medicare Advantage. We've been a VBID participant, from day one. I think a big role that government has is doing the more models the government does and the more mandatory models does, we love, because it is so much easier to go out to the market and to a provider and say, well, this is where the market is moving, because we want to do it versus this is what government is doing and we want to. I think, there are two really good days for me. There's when our competitor Highmark innovates is the day that I get to innovate, and when CMS announces something, I get to come and say, well, the government's doing it, let's figure out how we can do it. And so those are the two. I think the government has an enormous power to really kind of move the market. And the space that we're right now that we're super excited about is the kidney space with the mandatory bundle and the mandatory models announced there. There's just a huge opportunity to really disrupt that space.
Thanks, Alefiyah. Looks like we're about to wrap, but Anthony, maybe a 30-second little tidbit.
I love it with CMS. Grateful for CMS colleagues for pushing risk down, because that really changes the provider mentality, and that's really when we can really come in and really partner instead of heads and beds. We're fixated on value creation, so that's what United is excited about.
Well, please join me in thanking the esteemed panel for their commentary.